I am going to introduce my course co-chair, Tess, Dr. King, and then let her introduce her colleagues for this next talk on primary care practice updates in women's health. So
Great.
Tess King is an assistant professor in the Washington State University Allison S. Floyd College of Medicine and an assistant program director with the WSU Internal Medicine Residency Program. She's a primary care doctor in the Providence WSU Internal Medicine Center in Everett, Washington, where she runs the Women's Health Clinic and resident curriculum.
Excellent. Okay, well, I will get us moving in our next talk here. This talk for this next hour is going to be primary care practice updates, specifically in women's health. And I will be joined by two wonderful colleagues of mine, Addie McClintock. Dr. McClintock is an associate professor of medicine at the University of Washington and practices primary care at the UW OBGYN and primary care clinic. And Dr. Sarah Reiger is an internal medicine primary care physician at the OBGYN and primary care clinic at UW Medical Center Roosevelt as well. And thank you, Shri, for introducing me. Let me get back over to presenter mode here. Sorry, guys. Okay, so we're going to be just trading off a little bit here, but as I mentioned, this is our updates in women's health talk. We have an agenda filled, packed with some great updates to talk about. We'll be talking about BV partner treatment, cervical cancer screening guidelines, some breast cancer screening updates, contraception updates with the MEC, some menopause information, and if we have time, some cardiovascular disease and adverse pregnancy outcome. But I will start us out by passing to Sarah.
Thank you so much. All right, so I am starting with talking about BV, where there's some current updates. So, as you're all aware, BV is really common. It can affect up to about a third of reproductive age women, and recurrence is really common as well. So, you see more than 50% of women experiencing recurrence within a year of treatment. And the symptoms of the condition really are itching, discharge, discomfort. It can cause a lot of morbidity for patients. And BV is thought to occur when there's an imbalance in the types of normal bacteria that live in the vagina. It's not generally considered an infection, but this is in part due to the fact that past trials of male partner treatment, which included oral treatment alone, did not show an increased incidence of cure. And this was interpreted as evidence against sexual transmission. However, new data is showing that sexual activity really does play an important role in BV incidence and recurrence. And there's growing evidence about sexual activity being a significant risk factor. So there was this new study in the New England Journal of Medicine that came out that many of you might have heard about. I'm still talking, I can stay on the last slide actually. Oh no, here, no, you can go forward, sorry. That's changed how we're approaching BV treatment. So this was a randomized open label controlled trial that was conducted at health centers in Australia, really to determine if concurrent treatment with oral and topical antimicrobial of monogamous male partners of women receiving standard of care treatment, whether it would reduce risk of recurrence. So couples, monogamous couples were randomized into no partner treatment for the male with female partner treatment that included either metronidazole, 400 milligrams twice daily for 7 days, or if contraindicated, topical with clindamycin or topical metronidazole. Or into the other group, which included treatment additionally for male partners. Go back there. Treatment for male partners. And the male partners were treated with both oral metronidazole, the 400 milligram tablets twice daily for 7 days, in addition to 2% clindamycin cream applied to the penile skin twice daily, again for 7 days. And so the primary outcome was BV recurrence at 12 weeks. And this trial was actually stopped early after only 150 couples completed the 12-week period of treatment because treatment of women only was considered inferior. So recurrence actually occurred in 35% of women who had their partners treated as well, but it occurred in 63% of women in the control group. And this actually corresponded to a significant absolute risk difference of negative 2.6 recurrences per person year, so with a p-value of less than 0.001. And there weren't any serious adverse events recorded. Really, more than 46% of men said that they had nausea, headache, or a metallic taste, but nothing significant. These were common side effects of metronidazole. Okay, and then the next slide. So really, as a result of this study, there are new recommendations that we're seeing now to include counseling around partner treatment for BV. So initially, I was just seeing this update in Up to Date, where the authors were recommending treatment for male partners as well. So females should receive standard of care, and then additionally recommended to counsel them that their partner should seek care to consider getting treatment with oral and topical antibiotic treatment. And then ACOG recently, not very long ago, less than a month ago, actually came out with a new clinical practice update. And they really recommend shared decision making. So to consider concurrent sexual partner therapy with this combination oral and topical treatment. And they're recommending it actually for recurrent symptomatic BV. So not just any patient who tests positive for BV, but ones who have had BV before. And ACOG's really making this recommendation for recurrent BV instead of the first episode, likely because the study population really had a high burden of BV risk factors. And actually, BV recurrence in the study population was more than 80%. And that really impacts the generalizability of the study. Additionally, they had other high risk factors for recurrent BV like IUD and non-circumcision. And then ACOG also actually, in addition, so taking it kind of to the next step beyond the study, recommends shared decision-making regarding concurrent partner therapy for adult patients with same-sex partners, actually. And while this wasn't in the study, I think there's additional thoughts about the sexual transmission of this. And so having that conversation as well is recommended. And so really, what does it mean for us in practice? I'm encouraging patients to have their partners seek care from their own healthcare practitioner to get the dual treatment. Right now, expedited partner therapy isn't recommended as a treatment strategy for BV like it is for chlamydia or gonorrhea, generally because it's regulated by state and local laws that would impact this. So something to think about now as you're seeing patients who are testing positive for BV. Right. And then along the next line of recommendations, so cervical cancer screening updates. So just generally to review regular cervical cancer screening. So current guidelines for cervical cancer screening, as many of you are aware, are really two different recommendations. So USPSTF and ACOG recommend starting at 21 and ending at 65 with cytology for everyone every 3 years, or generally what we do is age 21 to 29 with cytology every 3 years, and then over 30 doing HPV-based testing. And then ACS came out with more recent guidelines a few years ago, which actually has us starting cervical cancer screening at 25 instead of 21, with the recommendation for most people getting HPV-based testing every 5 years. And then recently, however, so just at the end of last year, the U.S. Preventive Services Task Force came out with updated draft recommendations, and really it's around sort of the new conversation around FDA approval for self-swabs. So the biggest update here, it still recommends starting at 21. It still recommends cytology every 3 years. Before 30, and then after 30 doing HPV-based testing. But the real difference is that it says that for those over 30 years old, they could do HPV clinician or patient collected cervical cancer screening. And so basically there's some conversation still going on around this. There's concern that they're sort of equating clinician-based testing with patient-collected testing, and there's no conversation around which FDA tests to use. So it's part of an open conversation that's happening. So speaking to the next slide, I wanted to talk a little bit more about what the current recommendations are for HPV self-swab. Self-collection for HPV screening was actually approved in 2024, but there's been really no clinical recommendations around practice. The self-swab has actually been shown to be relatively high in sensitivity and specificity compared to clinician-collected cervical swabs. And so as a result, we've implemented it in many clinics. It's currently implemented in our UW clinics, and many of you might be seeing it in your clinics now. However, it's not really appropriate for every patient. And there's updated recommendations from the Enduring Consensus Cervical Cancer Screening and Management Guidelines Committee that were released earlier this year based on a comprehensive literature search and systematic review. So just going through the recommendations, which seem like a lot of words, you can go to the next slide, but I think are pretty straightforward. Is it really the first recommendation is that clinician cervical testing really is preferred. So whenever anyone comes through the door, I generally say I'm going to do a cervical collected pap, but this self-vaginal swab really is acceptable, and acceptable especially as it expands access for many under-screened patients or never screened patients, particularly those who wouldn't tolerate a speculum exam. The real reason why they're recommending the clinician cervical testing as a preference is that it allows for a cervical exam and it prevents the need for them needing to come back if there's an abnormal test because you've done the reflex cytology that can be reflexed there. So next recommendation. So this was a question I had as I was starting to implement the self-swabs is really how frequently should we be doing these self-swabs? And what I'm seeing is that now they're recommending to repeat it in 3 years. So if it is a normal test, then they can repeat it at 3 years and continue to repeat it at 3 years until they turn 65. And then the question is sort of what happens with a positive test. So the next sort of goes into the next recommendations go into the more nuanced understanding of what the positive test should be. And really, anytime anyone tests positive for 16, 18, these are high risk HPV tests, they should go directly to colposcopy. They don't have to come back in for a cervical swab. You can just send them directly to the colpo clinic. If it's high risk HPV that's untyped, then you want to have them return for cervical cytology to actually be able to do the swab to see if there's ascus or normal cytology or CIN, anything like that. And then oftentimes we don't have the expanded testing, but if your pap smears allow for sort of broken down testing and they test positive for 56, 59, or 66, they can repeat the pap at 1 year. So they don't necessarily need to return for the cervical cytology immediately, but instead you would have them come back. And then that speaks to the next question of really after an abnormal pap, one last thing, that clinician collected sampling is preferred. So if they've had a positive pap in the past, you really want to have them come back to have that cytology swab, the cervical swab. However, if they're going to not otherwise get testing, then the vaginal specimens allowed after shared decision making. Great. Thank you. Okay, and so these recommendations really only apply to the tests, so the collection kits and the HPV assays with an FDA approval for the primary HPV self-collected screening. So you can't just use a cytobrush in your clinic to do HPV self-swabs. Instead, you have to have the specific kit and know that your lab will run it. And so far, it's just the BD on Clarity HPV assay with the Copon swab. You'll kind of know if you ask your lab, or the Roche Cobas assay. And I think we have the Cobas assay within UW. So something to ask about if you don't know. And just a reminder that these recommendations really apply to average risk women. So not everyone coming through the door should be kind of counseled that they can have an HPV swab. I'd say so people living with HIV or otherwise immunocompromised have different requirements for testing and generally need cytology. Those with DES exposure as well, those with surveillance after colposcopy, or those with any adenocarcinoma in situ really shouldn't be getting self-swabbed and instead need sort of the full cervical swab testing. Great. And so that speaks to the fact that there's been actually some new guidelines or new review of guidelines that were released for other immunosuppressed women not living with HIV to think about their cervical cancer screening. And so just to review, those with single organ transplant, end-stage renal disease, stem cell transplant, and lupus actually should all be getting the same cervical cancer screening schedule that people living with HIV get. So that would be basically they get a baseline test of cytology, and then they get an annual test of diagnosis every 3 years, and then they can move to annually, for 3 times, and then they can move to every 3 years. Also, patients who have IBD, RA, and MS that are on immunosuppression should remain on that schedule. And I think the big part of this review really was that there's weak evidence that shows that those with IBD, RA, and MS not on immunosuppression and those on disease-modifying therapy or monoclonal antibodies, there's weak evidence that they have an increased risk of cervical cancer and HPV as well. And so that we don't necessarily need to be doing more frequent testing in them. However, it's a shared decision making given that they do potentially have an increased risk. And so you could consider doing pap smears, cytology, and usually I'll do co-testing in all these patients. That's the recommendation. So co-testing every 3 to 5 years. And again, anyone within this group, I won't be offering the primary self-swab unless they absolutely cannot tolerate a pelvic exam. And so just generally to summarize everything we talked about, so overall, the cervical swab really is preferred, but the self-HPV swab is really acceptable for screening and is an incredible way to expand access for that average risk under-screened population. Just making sure that you have the appropriate order and lab test in your office. And then if the self-swab is negative, you're going to repeat it every 3 years, not every 5 years. And then just to think about the other high-risk populations, particularly those with IBD, MS, and RA, who could consider getting more frequent screening even if they're not on immunosuppression. I think that's it.
Okay. Thank you so much, Sarah.
Mhm.
So we're going to shift from cervical cancer screening to some new data in breast cancer screening. These are not full updates to the screening guidelines themselves, but really just some large studies that have come out that can color some of our screening and how we talk to patients about breast cancer screening. Before we talk about those studies, I just wanted to ground us, as we've probably all been aware, but just to highlight, there are many societies with breast cancer screening recommendations. The ones that I think many internists and primary care doctors follow are often ACP, maybe ACS, and largely USPSTF tends to be the ones that we look to. But many of these societies recommend screening start at 40, some at 50. But USPSTF had a major shift in 2024 that shifted it from 50 to starting at 40. And it remained that it recommended screening every other year. But just as we talk about these studies, just considering that there is a shift to screening people at a younger age. So now we are often talking to people who at the age of 40 about breast cancer screening. So the first study we're going to look at came out in 2024. This was a large study that was looking at the effect of false positive screening mammograms and how that impacts long-term retention in the screening program. So just some background on this, up to half of the women who get screened annually for 10 years at some point in that period will experience at least one false positive result, which is a significant amount. And this 2024 study really explores if that false positive result, when people get it, if that reduces people's likelihood of returning to breast cancer screening at their regular timeline. So this was a cohort study. It looked at a large population of just over 1 million women, all within that appropriate screening age of 40 to 73. It looked at a time frame of 2005 to 2017, so over a long period, and pulled data from over 170 facilities and eventually sampled 3.5 million screening mammograms. And some of the definitions to just keep in mind here, they looked at mammograms that came out as a true negative. So that if you think about your mammogram reports, a true negative would be anybody who had a BI-RADS report of 1 or 2. BI-RADS 1 being it is a negative, there's no findings. BI-RADS 2 meaning there is a finding, but it is definitively benign. So those are our true negative cases. Then they had 3 groups of false positives. So these are the false positive with additional imaging only. These were largely the BI-RADS 0 patients or reports. So those are when people had a report, but they got pulled back into imaging very quickly. They didn't need to wait 6 months or 12 months. They just had imaging either that day or shortly after. That was false positive group number 1. False positive group number 2 was those who needed a short interval follow-up. So those are patients who usually BI-RADS 3 end up getting recommendation to come back for follow-up imaging around 6 or 12 months. And then the third false positive group were those that got recommended for biopsy. So these are usually BI-RADS 4 or 5. So those 3 groups made up the false positive groups. And then they really were looking at, in all 4 of these groups, what is the outcome meaning the return to screening mammogram, return to their screening timeline within 9 to 30 months. So in thinking about that, the results showed us that overall return rate for all groups was around 76%, but there was a significant difference in the different results that people got. So the true negatives had about a 77% return rate. For the false positives with that very quick imaging, additional imaging only usually on that day, they did have a drop of about 2%, but not as big as the next 2 groups, which are where we find a little bit more concern. So the false positive group with the short interval follow-up, meaning they need to come back in 6 months or 12 months, that had an almost 16% reduction in returning to screening. And the false positive group that required biopsies had a 10% reduction in return to screening. So these 2 groups were much less likely to come back for screening after those more involved false positive workups. They did see some health disparities here. The Asian and Hispanic women in the group did have the largest drop in screening return. And another piece that's important to note is just that this effect of not returning to screening did persist for these intensive false positive workup groups for 5 years. So just some practice pearls, just things to kind of bring into your counseling. I think the study called some of these things out too. As we all know, counseling around cancer screening is so important in primary care, but I think as we often feel the pinch of time, it can be hard to do. But I think really keeping in mind that as we're counseling patients, definitely at the beginning of their screening journey and their screening orders, that we are counseling them on the possibility and likelihood that they may at some point get a false positive result. Also important to just emphasize that if your patients are getting these false positive results that eventually turn into benign results, that they do still need to return to routine screening. Just because they went for that additional imaging and then eventually got a benign answer does not exclude them from needing to come back to routine screening, because those groups actually are at a slightly increased risk for noting a cancer later in life. So talk to your patients about the risk for a false positive result and what that could mean, and then emphasize that if that happens for them, they do need to get pulled back into that routine screening. Okay. The next study I'm going to talk about that relates to breast cancer is this BRAID trial. This is a really large randomized controlled trial, and this was looking at a comparison of supplemental breast cancer imaging for women who have dense breasts. This was a study that was just recently came out in the spring of 2025 in The Lancet. So background info here is that mammography does have a low sensitivity for picking up of imaging for women with dense breasts. We know that. The BRAID study here, which is the Breast Screening Risk Adapted Imaging for Density, that's their acronym. This was the first large randomized control trial comparing supplemental imaging with standard mammography in women with dense breasts who have already had a negative screening mammogram. And they broke out the supplemental imaging into 3 different groups. So we have an abbreviated MRI, whole breast ultrasound, and then contrast enhanced mammography. CEM is the acronym you'll see in the table next, and then the ultrasound is ABUS. So in this study population, this was an RCT done in the UK. It looked at a population of over 6,000 women, all between the ages of 50 to 70. And this was done between 2019 and 2024. This is an interim report from the study, so it's not the end of this large study that's been done, but this is the first large report we're getting from it. As I mentioned before, they broke those 6,000 women into 3 different arms. Roughly a third got supplemental, and again, these are all people who had they already had screening done, and the screening standard mammography was negative, and they were known to have dense breasts. They then got broken into 3 arms. A third got an MRI, a third got this whole breast ultrasound, and then a third got this contrast enhanced mammogram. The results that are important to pull out here, I think, are first to say, yes, in this second blue bar here, there was an increased cancer detection rate for actually all three of these. Definitely higher cancer detection rate for the two types of imaging that use contrast. So for the MRI, they pulled out 17 additional cancers per 1,000. And for the contrast enhanced mammogram, that pulled out 19 per 1,000 additional cancers. The ultrasound did pull out some more, not as high, only 4 per 1,000. But I think it's also important, just in the light of the last study we just talked about, that the recall rate is also high. So the recall rate from these was a little over, just under 10% for both the MRI and the contrast mammogram, and higher than the ultrasound at 4. So overall, the results that were pulled out in this from this study here, abbreviated breast MRI and contrast mammogram detected 3 times as many invasive cancers than the ultrasound. So if you compare the arms of the supplemental imaging, those do detect more cancers. They also detect cancers that are a smaller size. So the tumor size found by MRI and contrast mammo was also smaller than ultrasound. They also are picking up the contrast mammo and MRI. They're also picking up DCIS cases, which were not found in the screening mammograms. But again, the recall rates were more than twice as high in the contrast arms, so the MRI and contrast mammo, compared with the ultrasound. So at this moment, I think this is really interesting and exciting to think about. It does have a major limitation, though, that it is, as I mentioned, an interim part of this study. We have not yet looked at the longer term effects of this, so we haven't been able to see how the results are showing impact on breast cancer mortality or the harms of overdiagnosis. These are just initial detection measures. Future results will hopefully address this, but we don't yet have that. So I think as our patients are coming in to talk to us about their breast density, because they are seeing it in their mammogram report often, yes, the supplemental contrast imaging like MRI and contrast mammogram, there are ways that exist to improve our cancer detection rate for people who have dense breasts, but we do not yet know longer term outcomes. So at this moment, the USPSTF and ACP recommendations remain unchanged. That being said, they have not had additional updates since this data has come out. But at the moment, there is no recommendation for supplemental imaging for women who are average risk but still have dense breasts as their only risk factor. So we don't adjust how we screen them, largely because we don't have long-term data yet. But keep your ears open, because as things come out in the future years, we may see changes. Okay, shifting from cancer screening, I want to turn our attention to a great tool that we can use for contraceptive counseling. The MEC came out with a large update in 2024. This picture on the side here is just what it might look like if you have downloaded the app onto your phone or a tablet. It's a great app. Highly recommend you grab it. It is also free. So the MEC is the medical eligibility criteria for contraceptive use. It came out with an update in 2024 from the CDC, and that replaced the prior version, which was almost a decade old, from 2016. Goals from this new updated version were to determine the safety profile of contraceptive methods for people with various medical condition, also to reduce unnecessary medical barriers to contraception, always important, and it highlighted multiple points in time to support person-centered contraceptive counseling in a non-coercive manner. So for anyone who's just not super familiar with the MEC, the tables can be a little bit overwhelming, but just want to ground us again in what the categories are for when we're actually looking at that, at those tables we're seeing. The MEC is giving the guidelines of a category 1, 2, 3, or 4, and that is telling you the safety profile of that contraceptive method with that condition. So if it has a category 1, that is a condition, that is a combination of condition and contraceptive method that has no restriction. It is considered to be safe. Kind of works our way down to all the way to category 4, which is saying that condition and contraceptive method have an unacceptable health risk. They are not recommended to be used. And then of course, 2 and 3 are kind of our middle ground in between. So in thinking about that, I will say there are hundreds of different medical conditions that the MEC looks at and dozens of different types of contraceptive methods. So I'm not going to go through every tiny little change that occurred, but I want to just call some highlights out to maybe file away in your brain for the next time you're maybe counseling a patient in clinic, that you could use this great tool to pull up some information about that. So a major update here is that we did get new recommendations in this MEC to include contraceptive guidance for people with CKD. We also got revised guidance for many other conditions. There is an updated breakdown in all the different timelines that occur for contraception guidance for people who are breastfeeding, people who are postpartum. There's also new guidance for people who have obesity, increased VTE history, valvular disease, lupus, and different types of liver disease. And there's also expanded recommendations for those with HIV, which is just accounting for the new ARV regimens that have come out. Our new MEC also integrates several new methods and formulations that have become available. And then a couple things to note about some of the contraceptive methods themselves. The progesterone depot shot, there was some new data that is just bringing some more caution to using that particular method for those who have an increased VTE risk. So it got downgraded, I should say, from a class 2 to 3 safety profile for many conditions involving VTE risk. And then for progesterone-only contraceptive methods and combined hormone contraceptive methods, those got kind of upgraded in safety profile for several different conditions in this report as well. One other thing I want to highlight that is a piece of the practice recommendation that comes as a pair with the MEC is just that for patients who are transgender or non-binary who are using and who do have a uterus and are using testosterone, the use of testosterone is not alone an effective contraceptive method. That is not one of the recommended contraceptive tools for those patients, and you should be counseling those patients on using a different type of contraception if they would like to, if they desire to avoid pregnancy. Okay, so strengths of the MEC. It is a rigorous evidence review by a very large committee. It really looks at trying to give you clinical applicability for many different medical conditions and contraceptive methods. And there's really an emphasis on patient-centered care. Certainly a limitation for much of the information that's there is that some of these recommendations are based on smaller studies, just because it is really splicing into so many different types of medical conditions. But I just want to drive home some practice pearls here. This is what it would look like when you pull it up on your phone. As I mentioned, there is an app. The main practice pearl here is just to know it is out there. Put it on your device, have it in your hand. It's a really fabulous tool. The key thing here is just safety first. Yes, favor your safer methods. And I think to drive home the point that this is a tool, it is not a rule. So this is not to say you cannot make choices that do not perfectly align with what's there. Have a discussion with your patient, use this as information to ground into your conversation with them. And also part of the MEC in the recommendations on how to use this, they also highlighted that at the end of the day, your counseling can kind of you can look at it through the lens of, is the risk of this issue the risk of pregnancy for this person versus the risk of contraception method for this person higher. So, avoiding a method, but maybe that person having a high risk in pregnancy if they were to get pregnant is sometimes a helpful lens to look at too. I will just kind of show you what it looks like as you pull it up. You pull open the app. You can select by condition or method. You can click through. You can even select several conditions, and then it will show you a screen with the different methods and their various MEC categories for safety as well. Okay, I will close us on contraception and the update on MEC and pass it to Addie, who's going to talk to us about menopause updates.
Everybody's favorite topic. I chose this topic because although I'm not necessarily focusing on things from just the past year or two, I wanted to help us be ready to answer the many, many questions we, in our practice at least, are starting to get about menopause and perimenopause. I took this image from a direct-to-consumer menopause website. And as you can see, and maybe have noticed in your practice, there is a whole range of symptoms that people are going to the internet to understand and coming away with information that sometimes might not agree with our understanding of how to best help them with that. Next slide. In that spirit, I do want to point us all to a very useful resource, which I do trust, for helping people think about tools that they may have for symptoms that are bothering them. So this website is called My Meno Plan, and you can do this with your patient or you can send them to this website, but it's meant to be sort of for patients. They can sort of pick up to 6 at a time symptoms that are bothering them and that they're seeking help for. And then next slide. They can also sort by looking at this top part here by sort of what type of therapies they're interested in learning more about. So is it about medications? Is it about herbs or supplements? Is it about mind body? Only treatments known to help, because as you can see, what this will sort of give them as a readout is what are the symptoms along the top, and then along the side here, what are some of the sort of tools they might have, and then whether they help or may help. And all of these links along the side, if a person clicks on them, it will give them both like the specific strategies or information about that specific therapy, how to do it, how to access it, and the evidence behind it. So this is a great resource. It can be helpful for us as well, but also for patients as to sort of a reliable place that I feel comfortable sending people if they want to be searching the internet. Next slide. Okay, what I'm actually going to talk about today, though, and spend most of our time, is talking about some new reviews and guidelines that came out related to symptom management. And I want to talk a little bit more specifically about HRT and cardiovascular disease. We've had a couple big papers published in some of our major journals that I just sort of want to make you aware of. So guidelines that came out, and I put recently because this is more in the past, 3 years, but in 2022, NOMS, the North American Menopause Society, put out a position statement on the use of hormone therapy. They followed that in 2023 with this position statement on non-hormone therapy. And then there was a review just recently published called State of the Art in Menopause, Current Best Practice Approaches from the International Menopause Society World Congress in 2024, which was held in Melbourne. So those are 3 big guidelines that have come out for us to sort of reference in the past couple years. We also, sort of on the heels of many of those guidelines, had new reviews published in JAMA and BMJ. So there was a review on menopause symptom management, the Women's Health Initiative randomized trial and clinical practice kind of updated review, and then another review, management of perimenopausal and menopausal symptoms. So all of those have come out in the past couple years, sort of on the heels of those large new guidelines. I want to just sort of focus on, there's some nuance between all of these, but I want to mostly focus on what are the main core points I hope you will remember or know. And some of these you may already know. I wouldn't describe anything here as earth-shattering if you already do some amount of menopause care, but I will go over them nonetheless. So MHT, menopause hormone therapy, is safe for most women to use who are within 10 years of menopause. And here I'm using women, I should have said female patients. We recommend using MHT for 5 years, then individual periodic reassessment. So there is no hard and fast cutoff age that you must stop purely from an age perspective. We do recommend 5 years, but you don't have to cut someone off at 5 years if that's not within their significant goals. We should, however, avoid MHT if their ASCVD risk is deemed to be greater than 10%. MHT should not be used for prevention of chronic diseases, and I have an asterisk there because estrogen does have an FDA indication for prevention of osteoporosis. So that is sort of the one exception we might consider. It's recommended specifically for moderate to severe hot flashes. So as you are probably all well aware, there are a number of reasons for which people may now be requesting MHT, but this is really the specific indication. And then there are many non-hormonal options if someone is not a candidate for estrogen therapy. Just to go over some of those interventions, so these recommendations come specifically from the NOMS non-hormonal statement, although they do appear in other places. But NOMS reviewed the data for many of these, and overall, they said they recommend CBT, which can be done in a group setting or even individually, like through apps and whatnot. Hypnosis has good evidence behind it. SSRIs can be used, SNRIs can be used, gabapentin, fezolinetant, which is a novel agent that works sort of at the brain thermoregulatory center, which is fascinating, very cool new therapy. And there is another one that just came out that's name I don't have on here, but I have not used it. And then stellate ganglion blocks. Not recommended are things like paced respiration, most supplemental herbs or remedies, including black cohosh, which we often see. Exercise, of course, exercise is generally recommended, but not as a way of managing hot flashes. Yoga or mindfulness-based interventions, soy, acupuncture, cannabinoids, clonidine, and pregabalin. And I do still see clonidine recommended in some places, so I think that one you may see different things in different guidelines. And you may want to use it for other reasons for people, in which case maybe someone could have a benefit. That's fine. Thanks, Tess. Okay, DHEA is another one we get a lot of questions about. So DHEA, intravaginal DHEA, which is marketed as prasterone, can be used for GU syndrome of menopause, and it is approved by the FDA for severe dyspareunia from GU syndrome of menopause and can improve symptoms by 40 to 80%. Does not cause endometrial hyperplasia when studied up to 52 weeks. So people typically do not need some other sort of endometrial protection if they're using this. It is not recommended for systemic use. Okay, testosterone, everybody's other favorite topic. So a couple things, I left some very specific recommendations here on the slide. I'm not going to read them, but if you just listen to me, then you can later look these up more specifically. Overall, testosterone is really not mentioned in any of the guidelines that I showed you earlier. Some of the reviews do discuss it. And then there are other places where it is specifically recommended by these societies, but just sort of in a different place. So the IMS World Congress guidelines do actually mention it. Menopause Society, so same NOMS, does have a practice pearl related to testosterone use. And then the International Society for the Study of Women's Health and Sexual Clinical Practice does support its use. So all of these places support its use specifically for hypoactive sexual desire disorder only, and only in postmenopausal women. And then we always like to note in these CMEs that when things are off-label, so this is off-label use of testosterone in the United States. It does exist sort of as an approved for medication in some other countries. So a couple things about this disorder and about treatment. So number one, it's a clinical diagnosis. There's no labs that you need to draw. There are some pre-testosterone sort of non-pharmacologic interventions recommended first, which I'm not going to cover here. Testosterone can be used at a basically 1/10 the dose we use in male patients to treat this for female patients. You do not need to check testosterone as part of a diagnosis. You should check a testosterone before initiating therapy, and that is only to make sure that they are in the appropriate range where they are not going to end up like higher than a physiologic range. And then you should check periodically again, making sure you've not superseded a physiologic range for a premenopausal woman. I actually recently went to the UW Medicine lab guide, so I can only speak to UW Medicine, but we do have sex-specific and age-specific normal ranges. So you can use that to guide. You don't have to worry too much about whether, like, which range to use. It will specify that in your result. And it should be used for about 6 months. And if at that time it's not improving, you should stop. But if it is helping, then you can continue. Okay, next slide. Okay, here's another one we get a lot, MHT or contraception. So we have a lot of patients in our practice, at least, who are fairly young, I'd say even in their 30s, sometimes in their 20s, or in their 40s, coming to us about symptoms of perimenopause and requesting to be put on MHT. For people who are under 50 and don't have any other contraindication, those patients need contraception. Although it is unlikely that they will get pregnant in that 40 to 50 range, they can. So they need to have contraception. The other like semi no-brainer for people who are appropriate candidates is people over 55. They do not likely need contraception and you can offer them MHT. people in that 50 to 55 range can be a little tricky. Again, I've left this table here, which does have some specific guidelines that came from that BMJ review about what to do. Menno Practice Pearls also has a guideline like this that essentially says within 40 to 50, you have options for sort of what to do next. You can stop their OCPs, ensuring that they have a backup method in that time, and test their hormones to see if they've completed the menopause transition at that time, and then decide what to do. Then maybe they need to go back on their contraception, or you can switch them to MHT. Most of these guidelines actually say that up until 55, it is okay. Most guidelines sort of say contraception till 50, but some of the ones related to menopause say up to 55 is probably okay, as long as they're otherwise healthy. Okay, next slide. Okay, another question we're getting based on the internet, progesterone for sleep. So I can't sleep, I'm having terrible hot flashes, I'm in perimenopause, and I want progesterone for sleep. I saw this on the internet. So I was fascinated by this. It turns out progesterone metabolites are positive allosteric modulators of the GABA A receptor. And so they actually produce changes to sleep architecture that are very similar to the type that you get with benzodiazepines. This was a review in the Journal of Clinical Endocrinology and Metabolism, and it included 9 randomized control trials for a total of 388 sort of unique participants. Then they found that compared to placebo, micronized progesterone improved total sleep time and sleep onset latency, and then it improved self-reported sleep outcomes for most trials. All of the studies, or most of the studies, were in postmenopausal women, so not perimenopausal women. And then 4 of the studies in this review did include concomitant estrogen use, and so they obviously note that that's a little bit of a potential confounder. Next slide. They then looked at just the studies using placebo versus a progesterone and using polysomnography. So that was about, I think, 4 studies in the end. And they did see that micronized estrogen favored micronized progesterone for sleep onset latency, but not total sleep time or sleep efficiency. Noting that the oral forms are more effective than intranasal forms. I've actually didn't even know intranasal forms existed, but apparently they do. So overall, next slide. It does make physiologic sense that this would work. It works reasonably well and does actually even have sort of like subjective report of improvement, even without necessarily having objective evidence of it. And its use in the US for sleep is off-label. Okay, on to our next big topic, MHT and cardiovascular disease. So 2 studies came out in the past year or so looking at menopause hormone therapy and cardiovascular risk. So the first one is a Swedish nationwide registry based study called an emulated target trial. And basically that is a way of using observational data to sort of simulate a randomized control trial. It's a very cool methodology that I had not come across before. And then the second one is a reanalysis of WHI randomized clinical trials, looking at sort of composite cardiovascular outcomes across specific ages. Okay, so we'll talk about the Swedish hormone. Well, first we'll say what's already known. Prior studies indicate that starting MHT greater than 10 years after menopause or after age 60 might increase the risk of heart disease, VTE, and stroke. So this is what's called the timing hypothesis related to the WHI data. But there hasn't really been a way to sort of test that more clearly. And then most studies of MHT are now considered sort of older regimens. So when we look at WHI data, they're using regimens that are available and can be used now, but are not what we often use. Okay. So this methodology from the Swedish study, essentially they took women who well, first, let me say there were over 900,000 women in the study, age 50 to 58, and they were followed for 2 years after enrollment. So essentially, every month they initiated a trial where any woman who had filled or not filled a prescription for MHT was entered into like a trial. And they did this 138 times over the course of whatever, however many months that is, and then they watched them for 2 years. They did both an intention to treat and a per protocol analysis. So the intention to treat was whether they just filled it in that time. The per protocol was when they then followed them out to ensure that they were continuing to take it and putting them into sort of like the correct bin as they did the analysis. Okay, next. So this is a subset of, I just chose sort of like what are the most important data. But what they saw was that there was an increased risk of ischemic heart disease with oral combined MHT. So you can see that, oh, sorry. Where am I? Combined estrogen. Combined, here, sorry, right here, first one. And then there was an increased risk of VTE with oral combined MHT and combined transdermal MHT. This is interesting to me because we often think of estrogen alone as being pretty safe from a cardiovascular and VTE standpoint, which we do see here. But when you combine it, it doesn't actually look all that different from some of the other ways in which we give a combined product. So we haven't really, although this is not an RCT, we haven't really had another way of sort of testing these in a head-to-head way, the way they sort of attempted to do here. Okay, next slide. So it breaks down more granularly the risk for cardiovascular endpoints and examines more contemporary modes of delivery, which again, as I mentioned, anything using WHI data is not really able to compare sort of older regimens to newer regimens. And what it sort of tells us is that most methods are relatively safe from a cardiovascular standpoint for women who are 50 to 58 and meet the standard eligibility criteria. In that sense, it doesn't tell us anything earth-shattering, but it does allow us to compare some of these methods that are a little bit, and some of the outcomes a little bit more granularly and sort of with modern methods. Okay, next. So now looking at the other study that I mentioned that came out. So this one, the novel features of this one are that it did use WHI data. So that means that it's only using, as I mentioned, those older regimens. However, they chose just a subset of women who reported vasomotor symptoms, which is not how the WHI was sort of designed. In WHI, it was looking at assuming that it would reduce cardiovascular risk, and they put everybody entered on the study on MHT at the time point of start, regardless of their age. And then, oh, sorry. And then they looked at what happened. And so people with VMS who are specifically those that we would now treat are the ones who were included in this particular study. They grouped them by age pockets, so 50 to 59, 60 to 69, and 70 older. And then they put ASCV outcomes together and as a composite, which was overall to sort of between the grouping of the ages and the ASCVD outcomes together, that was able to give them adequate power to do that analysis. So the things that they found, sorry, Tess, thank you for going forward, were that in women 50 to 59, reduced MHT did reduce VMS without any increases in ASCVD related clinical outcomes. They said that in ages 60 to 69, there's no clear signal of harm, but they do recommend caution, not because of the signal of harm, but because there is just a rising risk of ASCVD within that age group from age alone. And again, this is for initiation. And then women 70 and over recommended against initiating because there was substantial attributable risk for ASCVD from the MHT itself. So overall, again, nothing earth-shatteringly huge and different, but I think it does give us a little bit more evidence for this timing hypothesis and some of the value of starting young if we're going to use it, and for those who are older, being more cautious or recommending more strongly against.
And then we only have about 8 minutes left, Tess, so I wonder if it makes sense to just move on for questions, or do you feel like we have time?
I don't see questions yet put in the chat. So if you want to, yeah, I think we could, it's a short section. So if you want to take a couple minutes and go over it, I think there's
That
time.
sounds fine. Feel free to interrupt me then. So I just wanted to take a moment to also talk about cardiovascular disease, but cardiovascular disease risk in the context of prior adverse pregnancy outcome. And so adverse pregnancy outcomes are very common, and I feel like becoming more common actually, and they are associated with long-term cardiovascular disease risk and kidney disease risk. There's a lot of data out there that's showing that. And so when I talk about adverse pregnancy outcomes or APOs, I'm speaking about gestational diabetes, preterm birth, gestational hypertension, preeclampsia or eclampsia, placental abruption, or small for gestational age or intrauterine growth restriction. So these are the findings that are associated with long-term cardiovascular risk. Let's go into the next slide. So the American Heart Association has been trying to put together data around how to improve these risk factors. So in 2024, they revised its scientific statement and reviewed current evidence around interpregnancy and postpartum preventive strategies around blood pressure management, lifestyle interventions, and really trying to figure out how to better optimize these patients' cardiovascular disease risks. And they do it within the framework of using the AHA's Life Essential 8 framework. But speaking sort of to the postpartum timing and interpregnancy care, so most of the care postpartum for someone with an APO is done by their OB-GYN. But around 6 weeks, and after 6 weeks is really when they transition to a primary care doctor. And so the AHA sort of speaks to what we should be doing in follow-up. And so really it's around transferring care to the PCP after 6 weeks, counseling patients so that they're aware of their increased risk, and then continued monitoring. So recommended blood pressure monitoring at 12 weeks, 6 months, and 1 year at least. Oftentimes, especially with postpartum, preeclampsia or gestational hypertension, blood pressure should normalize by around 12 weeks to baseline if they haven't been diagnosed subsequently with hypertension. And then we should be getting labs and screening these patients more regularly. So at least annually getting a BNP, getting a urine albumin to creatinine ratio, getting cholesterol and an A1C, even in patients whose blood pressure is normalized, they're at more 8 times risk of getting developing hypertension, and again, significantly increased risk of cardiovascular disease. And we're still trying to figure out ways to provide interventions to decrease or mitigate this increased risk. So there was a recent study that was done. It was a prospective cohort study of more than 100,000 women from the UK Biobank that was used to assess whether better cardiovascular health is associated with a long-term risk reduction of cardiovascular disease in women with adverse pregnancy outcomes. So basically, like, is there a point of even trying to do these things? Will it impact their cardiovascular disease health? Or because they had preeclampsia, is it just a sign that they're going to get heart disease? And so basically they use the Life Essential 8, which is this circle that we have here, but essentially it's a score that they made that's comprised of health behaviors. So diet, physical activity, smoking, and sleep, and then 4 metabolic factors. So body mass index, cholesterol, glucose, and blood pressure. And basically what it found was that among women with a history of adverse pregnancy outcomes, better cardiovascular health, so a higher LEH score, was associated significantly with a lower incidence of cardiovascular disease, particularly AFib and heart disease. And really that excess risk of cardiovascular disease associated with the APO really does seem to be attenuated by those who have a high LEH score. And so you can kind of see within these hazard ratios that the incidence of CVD overall was significantly lower in those who had APOs and had a high LEH score compared to those with the low LEH score. So there's no overlap within the confidence interval. And so the point really is that, women who have had these pregnancy outcomes really may benefit even more from maintaining better cardiovascular health than women without a history of adverse pregnancy outcomes. And so it just speaks to being able to, or it being necessary to better counsel them and clarify the importance of all this. And that's it.
Thanks, Sarah. Okay, I think we have a minute or two, a couple minutes. We can wrap up. If there are any questions, please feel free to put them in our Q&A box. Covered a lot of ground somewhat quickly. And if not, that's okay too. Can take a couple minutes of just a mid pre-course break for everybody to refresh before the next 2 sessions.
No questions?
I know, I'm surprised.
It was just that clear and good.
Or that overwhelming. Lots of information.
That could be the point. Okay, that's all right. I think, why don't we do this then? I don't see any questions coming through, so I'm gonna stop that.